Thank you for attending this candidate seminar for the Department of Epidemiology. Today, I'm pleased to introduce Dr. Rebecca Conway, who is the director of the American Academy of Epidemiology, Incorporated, which is an epidemiology and biostatistics research and consulting firm. Prior to this, Dr. Conway was an associate professor at the University of Texas Health Sciences Northeast, where she leveraged multiple large population and clinical research studies to identify risk factors for type 1 and type 2 diabetes complications. In this position, she also served as the diabetes epidemiologist for the CDC's Diabetes Control and Prevention Program. Today, Dr. Conway will be giving a talk titled Studies in the Late Complications of Type 1 and Type 2 Diabetes. Before I hand the mic over to Dr. Conway, I'd like to remind everyone to keep themselves on mute and please hold questions until the end of the talk. Dr. Conway, whenever you're ready.
Thank you. So I want to thank you for this opportunity of interviewing here at the University of Denver. And as she just mentioned, today I'll be presenting some of my research on diabetes complications. And this will be coming from studies from the Epidemiology of Diabetes Complication Study and the Southern Community Cohort Study. So, just a minute.
Sometimes if you're having trouble, there you go.
Thank you. Yeah. So I want to start with, this is an outline for today's presentation. So a little bit about me. I'll start with describing a little bit about myself, although I just got a very great introduction, so I appreciate that. And then I'll demonstrate some selected research from these two cohort studies, and I'll talk about my future directions. So about me, I'm an epidemiologist. I received my PhD from the University of Pittsburgh and then did a 3-year postdoc at Vanderbilt University Medical Center. And as an epidemiologist, my research focuses on the late complications of diabetes, but I also dabble a bit into clinical informatics. And as a teacher, I have a real passion for my students to succeed, and that means equipping them with the skills that enable them to hit the ground running once they are employed in the field. And as she just mentioned one more thing, I recently started my own epidemiology and biostatistics consulting firm, and it's called the American Academy of Epidemiology. And so I just want to start by giving some of the student successes that I'm pretty proud of. I have published 13 manuscripts with students, and the students are usually first author, although a couple of times there are co-authors. 3 of my students have successfully obtained and nationally competitive CDC or NIH internships or fellowships. One former MPH student is an EIS officer. I have 4 MPH students who are working as epidemiologists in health departments or at the CDC. And 1 doctoral student is currently an assistant professor. So, as I mentioned, we're talking about complications of diabetes. And here's the problem, although this is, you guys, this audience I'm sure is very familiar with this. But if you're like me, you probably know someone with diabetes. You probably even have a family member who has diabetes. And in fact, 1 in 3 adults are expected to develop diabetes in their lifetime. So actually, last year, diabetes was the 8th leading cause of death in the United States, and it's only because of COVID it crept into the top 10. Between 2015 and 2019, it was the 7th leading cause of death. However, as we all know, diabetes in and of itself is really the problem. That is, people don't really die. They rarely die from high blood sugar. Rather, it is the long-term end organ complications of diabetes that are the problem. And by end organ complications, I'm talking about kidney failure, nerve damage, peripheral artery disease, diabetic foot resulting in amputations, eye diseases such as diabetic retinopathy, cataract, glaucoma, for which persons with diabetes are at much greater risk, and of course, cardiovascular disease. Cardiovascular or coronary heart disease is the leading cause of death in persons with diabetes, and diabetes is a leading cause of non-traumatic amputations and a leading cause of kidney failure in the United States. So, as we mentioned in the introduction, I essentially started off in diabetes epidemiology at the University of Pittsburgh, working with the Epidemiology of Diabetes Complication Study. And this is a population of adults with childhood onset type 1 diabetes. And some of my dissertation work followed investigations that were taking place here at the University of Denver. And that's why I wanted to present some of the EDC work here. And that's adiposity and calcification studies. So a little bit about the EDC study for any of you who do not know. The Pittsburgh Epidemiology of Diabetes Complications Study is a sort of a population-based cohort study of about 658 individuals who are diagnosed with diabetes in childhood. By childhood, I mean under the age of 17, between the years of 1950 and 1980. However, the study started, the baseline for the study was in 1986, between 1986 and 1988. The average age of the participants when they entered the study was 28 and had diabetes. They've been living with diabetes for almost 20 years at that time on average. This is a predominantly white population, about 98% white. And the study, we brought the participants in roughly every 2 years for examinations, yeah. So the first, what I'm going to present here, the first study I'm going to present to you from the EDC is about coronary artery calcification in this population. And coronary artery disease, and why did I look at that? Well, type 1 diabetes is traditionally characterized as, people with type 1 diabetes are traditionally thought of as being thin or lean. That is in the past. However, results from the diabetes control and complications trial, they observed that it was a great reduction in microvascular complications of those who received intensive insulin therapy. And by intensive insulin therapy, I'm talking about at that time 3 insulin shots a day or being on the pump, and also self-monitoring, watching their blood sugar levels at least 4 times a day. However, with this intensification of insulin therapy, this population also saw a great gain in weight. And that was of concern for people. They're like, well, generally we don't think of weight gain as being good. And so we weren't sure what this is going to mean for this type 1 diabetes population. However, in the New Jersey 725 cohort, and this is a cohort of African Americans in New Jersey with type 1 diabetes, BMI actually showed an inverse relationship with mortality. And so we weren't sure what we're going to find when we started investigating the relationship of adiposity with complications in diabetes in the EDC study. Change in treatment post the diabetes control and complications trial may have resulted in a greater overweight and obesity in type 1 diabetes. We now know that that's true, but at that time we weren't sure. And so we also weren't sure how this may have affected complications and mortality risk at that time. And I'm presenting you a little bit some older studies here. So my objective back then was to investigate the relationship of adiposity measures of cardiovascular risk, cardiovascular mortality, and all-cause mortality. And my working hypothesis is that adiposity would be associated with increased risk of cardiovascular disease and all-cause mortality. Why? Because we know BMI is bad. We know obesity is bad. And that's what we all thought at that time, most of us anyway. So, however, when I looked at it, what I saw, and this sort of fit the hypothesis. We saw with increasing tertals. We looked at visceral adipose tissue. We looked at subcutaneous adipose tissue. We looked at BMI, and we looked at waist circumference. And initially we used an indirect measure of coronary artery disease, which is coronary artery calcification. And we saw, as we expected, an increased prevalence of coronary artery calcification with increasing measures of adiposity. So here we have tertals of visceral fat with the presence of coronary artery calcification. Here we have tertals of subcutaneous adipose tissue with tertals of coronary artery calcification. Here we have tertals of BMI with presence of coronary artery calcification. And here we have the presence of coronary artery calcification with tertals of waist circumference. So our hypothesis is panning out. Then we decided, well, let's look at coronary artery calcification score, that is the severity of calcification. And we don't quite see the same relationships. So when we look at, we did look at this sex specifically. And so when we looked at median calcification scores, these are sex specific median scores, at the severity of calcification, the relationship begins to look a bit more nonlinear. So, and here we have in women in the yellow for visceral fat, we see actually a nice little J-shaped relationship. So increased coronary artery calcification in women with the lowest tertiles of visceral fat, and sort of flattens out in the next few tertiles. And we have sort of a U-shaped relationship in men, U-shaped, slightly inverse J-shaped here. But this relationship is not significant. When we look at subcutaneous adipose tissue, however, we actually see an inverse relationship between tertiles of SAT and the severity of coronary artery calcification, both in men and in women. We see the same relationship more strikingly with tertiles of BMI, with the severity of coronary artery calcification. And we see the same thing with tertiles of waist circumference with severity of coronary artery calcification. So what we see is that although measures of adiposity seem to be associated with the presence of whether or not they have any calcification at all, when you start looking at how severe this calcification is, that relationship disappears and it begins to be more, definitely see a higher risk in those with the lower amount of body fat. So then we decided, let's look at coronary artery disease. And in this particular study, although the main purpose of this particular study here looking at coronary artery disease was looking at glycemia, we also put BMI and waist circumference in our models. And here we're just looking at them. This is a non-adjusted relationship right here. So this is the baseline characteristics of the population and what their differences by these individual characteristics. So here we're looking at non-fatal coronary artery disease compared to those who never developed coronary artery disease during follow-up. And they were followed for about 16 years. And as you can see here, there's no relationship with BMI between the incidence of coronary artery disease in this type 1 diabetes population. And here we but we do see a modest relationship with increased waist circumference and the incidence of non-fatal coronary artery disease. And when we look at fatal coronary artery disease, we see the same thing. We see there's no relationship between BMI and dying from coronary artery disease in this population, but we do see a slight increased risk among those who have a higher waist circumference. And it seems to be stronger, in men, in women. And I will tell you that when we put these into multivariable models, the relationship with waist circumference just disappeared in both men and women. And then I decided, well, let's look at the ultimate outcome, which is death, BMI and all-cause mortality. And when I first ran these analyses, and I showed them to Dr. Orchard, he said, did you code the data right? This is not what we're expecting. And what we do see here is we see a sort of, this is our baseline BMI, and we have them stratified by BMI category. So our first category is a BMI less than 20. Then we have our normal weight population. This is our reference. And we have our overweight population, and then we have our obese population. That's study baseline here. And we see this sort of slight U to J-shaped relationship. But then when we look at their average BMI during follow-up, and their follow-up for about 18 years, the median follow-up time was 18 years, and during that time, 22% of this population died. We see a strong relationship between being what we call our underweight category, BMI of less than 20, compared to the normal weight, and a strong increased risk of mortality. If your average BMI during follow-up was in this underweight category, you had a much greater risk of death. And overall, though, we see this sort of reverse J-shaped relationship. And then we use our time-varying models, and we still see the same relationship here with BMI and mortality. Okay, so we decided, okay, well, let's look at change in BMI during follow-up, because we are looking at the relationship of, during this time period between the late 80s and when we ran these analyses in the mid 2000s, there had been a major change in the treatment of persons with type 1 diabetes. The population had gone from only roughly 7% of the population being on intensive insulin therapy to 82% of the population being on intensive insulin therapy. So there was a major change in how their diabetes was being treated during this time. there's 18 years. So we thought, let's look at change in BMI and risk of mortality. So here, this is our change. And so what we did is we took people who they had to have survived the first 10 years of follow-up. And then we looked at their change in BMI from years 1 through 10 with risk of mortality during the subsequent 10 years. And as you can see, what we did is we stratified this by tertiles of change. And those who were in the lowest tertile of change, so we have some weight loss and a little bit of weight gain, had the greatest risk of mortality. And as you see this clear linear relationship right here. And this is what was striking to me. So this is what I did in Pittsburgh. Then I moved over to Vanderbilt, and I'm going to show you the analysis I'm showing you next. Although this is done more recently, it's not published yet. But we see the same thing in the Southern Community Cohort Study. We see this sort of compared to those in a normal weight category, whether you're looking at Blacks or whites with this young onset diabetes diagnosed before the age of 30, we see this sort of protective relationship for being in the higher weight categories. And this is a middle-aged population here. And we sort of see the same thing in those diagnosed after the age of 30, but it's much more striking in our population with young onset diabetes. And again, more striking in whites. But so as I mentioned, this is data here. Here we're talking about the predominantly, almost exclusively white population. We see the same thing whether we're looking at whites or Blacks, this protective relationship between being, at least in young onset diabetes, or in anyone with diabetes really, greater adiposity and risk of mortality. So this here is the Southern Community Cohort Study. And what is the Southern Community Cohort Study? And this is a population I've worked with the longest. So the Southern Community Cohort Study is actually a cancer study. It's not a diabetes study like the EDC was. This is a cancer cohort. The goal of the study was to better understand the causes of cancer, in particular, what is behind disparities in cancer risk, this disparities by geographic area, disparities in race. And they also wanted to know, why do African Americans experience a disproportionate burden not only of cancer, but of other chronic diseases? And so to investigate this, they recruited participants from 71 community health centers across the southern United States, and really the southeastern United States. And the reason why they chose community health centers is because a major confounder when you're looking at racial disparities in any kind of health outcome is socioeconomic status. So they thought, well, let's compare really poor Blacks and poor whites. And so we can sort of, by study design, account for this socioeconomic SES confounding factor. And by recruiting from community health centers, you're also theoretically getting people who have the same access to healthcare. However, they also wanted to look at some people in the general population in these same states. So they did a random sample of about, in the same states, with about 15% of the population came from a random sample of the same state. Because it's such a large cohort, it took them 7 years to recruit all the participants. So the number of enrollees was 86,000. The time period for enrollment was from March 2002 to September 2009. And because it's a cancer cohort, the age range was from 40 to 79. So it's an older population than we're looking at the CDC. And these are just states where the participants were recruited from. And these little sort of purple diamonds, maroon diamonds, are the centers, the community health centers, or federally qualified health centers they were recruited from. And then this is what the population looked like at study enrollment, at the end of study enrollment by 2009. So it was about 60% female, about 2/3, by design, it was 2/3 Black, they oversampled Blacks, and 85%, as we mentioned, came from community health centers. Most of these are federally qualified health centers. It's a poor population. It's predominantly low income. However, compared to the general population, they were much poorer, of lower and less educated, much lower socioeconomic status. However, if you look at the BMI characteristics, they're pretty similar with the general population. It has a very high prevalence of diabetes at the study baseline. So this is a great population for me to work with. 20% of this population had diabetes at study baseline, whether you're looking at the federally qualified health centers or in the general population. And this is unfortunately what you see in the South and the middle-aged and older population. and they had a high prevalence of hypertension and smoking, and at least and the predominantly where most of the population was recruited from. So in this population, I wanted to look at variation in diabetes mortality outcomes. And the reason why I wanted to look at that was this came from me sitting in the office with my colleague Aaron Seacrest, and he was doing mortality studies using the Pittsburgh Diabetes Registry. And what he found was that mortality rates in African Americans compared with whites in the Pittsburgh Diabetes Registry were 3 times as high, even though their standardized mortality ratios compared to the Pittsburgh the Allegheny County general population and the U.S. general population, the excess risk in each race was the same, almost the same. So you had about a 6-fold excess risk in Blacks with type 1 diabetes compared to Blacks in the general population there in Pittsburgh. And you had about a 6-fold excess risk of mortality in Whites with type 1 diabetes compared to Whites in the general population there in the Pittsburgh area. And so the hypothesis was that the thought was diabetes seems to be affecting mortality similarly in each race. So it must be non-diabetes related factors that's causing this excess risk in the whites compared to the Blacks. And a major non-white diabetes factor would be socioeconomic status. And so when I got to the Southern Community Cohort Study, this was an ideal population to test that hypothesis. And so I looked not only at type 1 diabetes, but also wanted to look at type 2 diabetes. And another reason I wanted to look at type 2 diabetes was, well, rates of mortality in type 2 diabetes are also higher in Blacks compared to whites overall. Mortality. But when you look within people with diabetes, so for example, the Mr. Fit study, they found no difference in mortality risk in African Americans and African American men and white men with type 2 diabetes. So when you're only looking within the population has diabetes, and when you account for income, there was no difference in risk between Blacks and whites with type 2 diabetes. There's another study looking at Medicare for fee beneficiaries, and they also showed a higher all-cause mortality in African Americans in general, but no difference in African Americans compared to whites who had diabetes. So let's look at the Southern Community Cohort Study. It's just a brief characteristic of the population stratified by diabetes status. So here we're only looking at those who were in the community health centers for this right here. So what we find is that on average, the population without diabetes are about 50 years old, and fairly similar, even those with young onset diabetes. Those with older onset diabetes are slightly older in their mid-50s. The average age of diagnosis in the population, in our young onset diabetes population was 20, and those who are insulin only. And the population who are on insulin only, I used to find my so-called type 1 diabetes population. And those who are both on insulin and an oral agent, this is slightly older, and about 23. And then our population diagnosed, here we said again, in their late 40s, those who are diagnosed after the age of 30. If you look at their BMI characteristics, overall, it was a lean population in young adulthood for those without diabetes, and slightly heavier in young adulthood for those who were diagnosed under the age of 30, and those who were diagnosed over the age of 30, but a little leaner in those without diabetes. So here we're looking at mortality in African Americans and whites with type 1 diabetes. So what I did is I carried out standardized mortality ratios. I did it, I say by sex and race, but we're looking at we're looking at overall rates right here. So I initially ran analysis looking at comparing the African Americans and the whites in a Southern Community Cohort Study who had young onset diabetes, and by what my so-called type 1 diabetes, and this is again defined as those who were diagnosed before the age of 30 and who were on insulin as their only form of treatment for hyperglycemia. And for African Americans compared to African Americans with type 1 diabetes in the Southern Community Cohort Study compared to African Americans in the general U.S. general population, this U.S. standard population, we have about a 6-fold excess risk. For whites, the excess risk in the Southern Community Cohort Study for those who had type 1 diabetes compared to whites in the general population was about twice. It was about a 12-fold excess risk. However, right here, though, we might not be comparing apples with apples here when we're looking at, because we're looking at the Southern Community Cohort Study. We're comparing this low income population here with the U.S. general population. So that might not be the we're going to use that as one population, but another reference population was just to compare them to the source population, and the source population would be this the Southern Community Cohort Study overall. So we would call the Southern Community Cohort Study general health center population. So whether they had diabetes or not. And so when we do that, African Americans with type 1 diabetes in the Southern Community Cohort Study compared to the African Americans in the Southern Community Cohort Study overall had about a 3.5 fold excess risk. And we see the same things for whites in the Southern Community Cohort Study with type 1 diabetes compared to whites in the Southern Community Cohort Study overall. So when we compare poor African Americans with type 1 diabetes to just African Americans overall in the US population, we have a 6-fold excess risk. And we compare to poor whites in the Southern Community Cohort Study with type 1 diabetes compared to whites in the general population, we have about a 12-fold excess risk. However, when we're comparing poor African Americans with type 1 diabetes and to poor African Americans overall, we have about a 3.5-fold excess risk. And we compare poor whites with type 1 diabetes compared to poor whites overall, we have again about a 3-fold excess risk. So the excess risk is sort of they become the same. And then we did this also using Cox models, and here we have adjusted Cox models. So what this data seems to suggest is that indirectly, yes, it seems to confirm that hypothesis that socioeconomic status does seem to be driving the difference between the excess risk in Blacks compared to whites within those who have type 1 diabetes. So then, let's just see, what does it look like in our low income population? How do whites with African Americans with type 1 diabetes compared to whites with type 1 diabetes in this low income, low resource population? They actually seem to do non-significantly slightly better. I'm not sure why. Now, keep in mind, there are only 400 participants with type 1 diabetes here. And that's combined African American and white, so it's not a large population. What we did do, we also found, though, this is not homogeneous, because when we stratified by household income, so this is only when we looked at those in the 70% of the population who had an annual household income less than $15,000 per year. There's no difference in mortality risk at all between Blacks and whites with type 1 diabetes. We only see this difference. This protective relationship here is driven by the higher income population in the Southern Community Cohort Study. So in the 30% who had an annual household income greater than $15,000, the Blacks with type 1 diabetes tended to do a lot better than the whites with type 1 diabetes. And I'm not sure why that's the case. So let's move on to type 2 diabetes. We have a much larger population here. We had here we had roughly 15,000 participants with type 2 diabetes. And what we found here is that here we're comparing African Americans with type 2 diabetes compared to African Americans in a population without type 2 diabetes. This is in the Southern Community Cohort Study. We see about an 80% increased risk. And we see the same increased risk in whites with type 2 diabetes compared to whites without type 2 diabetes in the Southern Community Cohort Study. However, when we look just in the population with type 2 diabetes, and when I say type 2 diabetes, I'm talking about the population diagnosed at or after the age of 30. Here we have the whites in the solid black line and the Blacks in the dashed gray line. The whites seem to have a lower survival than the Blacks, given they have diabetes. It's actually they have about a 23% lower. The Blacks have about a 23% lower risk of death than the whites, given that they have diabetes. And this has actually been observed elsewhere. There's another population, I believe it was in England, that served the same thing. And some reasons that this is thought that may be is that in African Americans, the diabetes may be a bit more insulin. African Americans with diabetes, the type of diabetes may be less insulin resistance driven than other factors, and so that might be the reason for the lower mortality, because actually they have a lower cardiovascular. And we're going to get to that. You can see here, this is cause-specific mortality in Blacks compared to whites with type 1 diabetes. And this is a leading cause of death in this population with type 2 diabetes. They have a lower risk of coronary artery disease mortality, a 30% lower risk of coronary artery disease mortality. This is the biggest driver of death here. And when we think of insulin resistance as being a cause of diabetes and a cause of cardiovascular disease, it would sort of make sense why they have a lower all-cause mortality. But let's look at the other causes of death. And the Blacks with type 2 diabetes actually had a lower risk of acute complications. They had a lower risk of accidental death, whether it's homicide or suicide or other accidents. They had a marginally had a borderline lower risk of cardiac arrest. They did have a borderline, a suggested increased risk of dying from, this is not a good definition of death, but dying of essential hypertension. There really wasn't a difference in risk in cancer mortality. No difference in risk in sepsis as compared to what you see in the general population, where Blacks, I believe, have a higher risk of sepsis mortality. They have a lower risk of respiratory disorders mortality. And I know people don't like this. A lot of people don't like this definition of respiratory disorders, but actually, and this is not something I show in the, these are not studies I've done in the Southern Community Cohort study, but studies I've done in the C8 health population, and which is a predominantly white population. We do see that in that population, diabetes does appear to be a risk for respiratory disorders. So it's interesting to see that Blacks have a lower risk of dying from these disorders than whites. Again, I'm not sure what the reason is. As expected, they do have a higher risk of heart failure death and a higher risk of renal failure death, but a lower risk of coronary artery disease mortality. So this is I'm going to transition now to an area I've recently moved into in the past few years, and that's cancer as an outcome of diabetes. And that is, it's like, although cancer is not considered a complication of diabetes, there's a lot of evidence to suggest that, shows that people with diabetes have an increased risk of certain cancers like liver cancer, pancreatic cancer, colorectal cancer. And I've been looking at liver cancer and pancreatic cancer. And these are two papers that are recently published. This was accepted for publication this year. It's in press, and the other one was published this year. We're looking at racial differences in liver cancer, and that's what I'll be talking about next. So this is actually a talk I gave a few years ago at the ADA. So I'm sorry for those of you who have to listen to it again, but I just wanted to show you recent work I'm doing right now in the area I'm going. So liver cancer is one of the most common of the malignant cancers. It is the 5th leading cause of cancer death. Black Americans are at about a 2-fold increased risk of liver cancer compared to whites, and persons with diabetes are also at an increased risk of liver cancer. So here, as you can see, this is data here from, I'm sorry, I didn't realize you guys could probably, this is in your way here, my apologies. So here, as we can see here, this data from the Surveillance Epidemiology and Results Program, the SEER, the prevalence of diabetes and the incidence of liver cancer has risen steadily in both Blacks and whites since 1975. But as you can see here, both the prevalence and the incidences are higher in Blacks compared to whites. And so this is liver cancer. We're going to see the same thing here. This is the prevalence of diabetes. You're going to see the same thing for liver cancer. And so here we see the incidence of liver cancer in the U.S. over, from 1975 to 2015. And again, it's higher in Blacks and whites, but although it's increasing steadily in both groups, and it parallels what we just saw here for the prevalence of diabetes. Again, higher in Blacks and then in whites. And so common risk factors for liver cancer include hepatitis C infections, is probably the biggest risk factor, obesity, heavy alcohol consumption, fatty liver disease, cirrhosis, cigarettes, and overload disorders. This is my interest in liver cancer here. So my objective in this study here was to examine the relationship of diabetes with subsequent liver cancer risk and to examine whether the relationship between diabetes and liver cancer differed between Blacks and whites. I'm not looking at not looking at iron studies in this particular study I'm about to show you. So we investigated whether the relationship between diabetes and liver cancer varied between Blacks and whites. So cancers of the liver and biliary tract, hereafter I'm going to just call them liver cancer. We ascertained them by linking the cohort with cancer registries in all 12 recruitment states. And persons were followed from the time they enrolled into the SSCS until either they had liver cancer or death, or right syndrome because of incomplete registration with the liver cancer registries. So they were followed for about an average of 10 years. And we use a Cox regression analysis. So this is the characteristics of the study population here. We're now including not only just the community health centers, but the general population here. So we now have about 7 people in our cohort with diabetes at baseline, and about 65,000 without. As you can see, the people with diabetes are slightly older. They're more likely to be female, but in this population, there was a fairly similar proportion of Blacks and whites. Fairly similar proportion of Blacks and whites, and as a non-diabetic population. So persons with diabetes tended to have a higher BMI and a greater prevalence of both former and never smokers. They also tended to consume less alcohol and to be more likely to not have graduated from high school and more likely to have a household income of less than $15,000 per year. The history of any hepatitis infection, and we did not look at hepatitis C specifically, we looked at any hepatitis infection, was pretty similar whether they had diabetes or not, about 7%. So there were a total of 286 liver cancer events. And here we show liver cancer event rates in those with and without diabetes. Here are those with diabetes, and here we have those without diabetes. And as we can see, liver cancer event rates were in the, these are the liver cancer event rates in a diabetic population. And you can see it's slightly higher in the whites, but when you look at the non-diabetic population, it's quite a bit lower in the whites. So you have a slightly lower in the whites with slightly lower in Blacks if they have diabetes, but much higher in Blacks without diabetes. These are liver cancer rates. And now we're looking at the multivariable adjusted risk of liver cancer in the population as a whole. So this is not specific, stratified by diabetes. Stratified by race. Diabetes appeared to increase the risk of liver cancer in our population by 2-fold. But when we stratify by race, diabetes increases the risk of liver cancer in Blacks by 60%, but increases the risk of liver cancer in whites by 262%, like 3.5-fold. And here, now we're looking at it stratified by diabetes status. Among those with diabetes, there's no difference in risk between Blacks and whites. However, among those without diabetes, we have twice the risk of liver cancer among those Blacks compared to whites. And then here, we see the same, just a reiteration of these same results. And the population overall, diabetes increases the risk of liver cancer by 2-fold. It increases the risk of liver cancer in Blacks by about 60%. And it increases the liver cancer risk among whites by about 260%, 3.5-fold here. And so that's good here. And we have this significant race by diabetes interaction here. So we have an increased rates of liver cancer among those with diabetes, increases about 100%, increases quite a bit. Increased liver cancer rates among Blacks. Diabetes increased the rates of liver cancer among Blacks by 60%. This should be 260%. It increases the risk of liver cancer in whites. When both Blacks and whites have diabetes, there's no real racial difference in liver cancer. And some explanations for the differential effects of body fat on liver cancer risk in Blacks and whites. In our population, we found that having a history of high cholesterol was actually protective of liver cancer in this population. And it seemed to be even more protective in whites than it was in Blacks. Type 2 diabetes may be more heterogeneous in Blacks than it is in whites, and thus of the weaker association with liver cancer. And for a given BMI, whites tend to have more visceral adipose tissue, whereas Blacks tend to have more subcutaneous adipose tissue. And that might be reasons for causing a possible differential effect of fat deposition in the liver and subsequent fatty liver disease. So our findings, raise the possibility of markedly different effects of diabetes and the hepatic carcinogenesis between Blacks and whites through reasons we don't really know. And one of my hypotheses is iron. And so a future direction for me is to look at iron as an explanatory factor for racial differences in liver cancer, and iron another risk. This is a grant that I have already scored, looking at iron as an explanatory factor for diabetes risk in African Americans. And the reason why I'm looking at this is because even though African Americans have lower hemoglobin levels on average, and they have a greater prevalence of anemia, they actually also have they have more iron stored. They have greater ferritin levels, which is a marker of stored iron, body iron stores. So some of my other research interests include complications of type 1 diabetes and young onset diabetes, which I presented to you. I did not really look at present data on young onset diabetes. That was not my so-called type 1 diabetes population. I'm also interested in environmental contaminants as a risk factor for diabetes and looking at research using repurposed EHR data. And as I mentioned, I've recently started looking at cancer, and I just got a small, it's a decent, it's a VA contract to look at, to do a breast cancer study. So that's me, and I'll take questions now.
Thank you very much, Dr. Conway. It looks like we have about 14 minutes for questions. I'm going to start off with a question. I am quite surprised by the lack of disparity in cancer risk among Black versus white participants with diabetes. Do you have thoughts as to why this might be and what the implications are?
So I think even though diabetes increases the risk of diabetes in both Blacks and whites, it increases the risk to a much greater extent than white. That sort of levels the difference, that the excess that you would normally see if you weren't looking at diabetes. And so we do know overall that even though Blacks have greater risk, and we saw it in our data here, have greater overall cardiovascular disease, and we were talking about heart failure and essential hypertension, when we start looking at things like atherosclerotic heart disease, they have a lower risk of that. And so, and they tend to have, it's not that so much that Blacks have a better cardiovascular risk profile, lipid risk profile. It's whites tend to have a worse atherogenic lipid profile. And so we're talking about things like high cholesterol or triglycerides, and specifically we're talking about hypertriglyceridemia. That's what's going to be leading to your fatty liver disease, or the fat deposits in the liver. This is just a hypothesis. We don't know, but I'm thinking that it might be driven partially by that, but I don't know.
Okay.
But we do see that in other areas too. We see the same thing for mortality. You see excess risk overall, but within the diabetic population, that risk disappears or becomes even inverse.
Okay. That's really interesting. Thank you. I see that Donna has unmuted herself.
Yeah, very nice presentation, Rebecca. I was particularly intrigued by the data you presented on the comparison between African Americans and whites with respect to morbidity and mortality. both in people with diabetes and in the general population. And contrary to what some might have expected, a higher mortality or lower survival in African Americans, you saw the opposite. And I think what you're suggesting is that once you match for income, this was a low income population across the board, you no longer see an increased burden or decreased survival in African Americans compared to whites, but quite the opposite.
Yes.
Which would have been nice to have a slide to summarize that. Which is very interesting. These are data I was not aware of. So thank you for presenting the data. Do you have any potential explanations for some of these effects that you were observing?
So like a huge, as you mentioned, a huge confounder of racial differences by race, particularly when we're looking at Blacks and whites in the US, is socioeconomic status and access to healthcare. And in this study, most of the participants are being recruited from federally qualified health centers. So theoretically, they have the same access to healthcare. There are low incomes, you're comparing apples with apples, and then you're better able to really get at biological differences. And so if there are biological, if the pathophysiology of pathogenesis even, or of the disease is slightly different between the two races, maybe what's leading to diabetes in Blacks, what's causing it may be slightly different than what's causing it in whites. I mean, BMI is the biggest risk factor for both, for type 2 diabetes. But, and we have another paper that I didn't show you, even though it's the strongest risk factor for incidence of diabetes, it's a stronger risk factor in whites than it is in Blacks. So other things seem to be playing more of a role in diabetes, type 2 diabetes risk in Blacks than it is in whites. And so with whites, they seem to have more of an insulin resistance, even though it's insulin resistance in everyone, but it's more so insulin resistance in whites when you're looking at diabetes and when you're looking at Blacks. And if that's the case, maybe that's why they have a higher cardiovascular disease, coronary heart disease mortality, which is the leading cause of death in both groups. So
yeah, and I'm wondering what's the role of resilience in all this as well.
True, because what we saw when we looked at in the type 1 population, anyway, I'm not sure if this is what you're getting at, resilience. So when you're looking at a poor population and you stratify by income, although the very, very poor, there's no difference in risk. When you're moved slightly above that, so those with an income greater than 15,000, which still isn't very much, the Blacks do a lot better than the whites in survival. And is that what you mean by resilience?
That's kind of what I'm talking about, right? Okay. In face of similar adversities, it seems like based on your data, African Americans are doing better than whites. Much more resilient.
Yeah, given they're not extremely poor. When you get to the lowest levels of poverty, they seem to be doing the same. Yeah. So yeah, it's actually we saw that in West Virginia for sure. When you get down to that, it's. Are there other questions?
Well, until somebody else voices one, I have another question about that interesting relationship. Again, you were today showing us, I think you wanted to provoke us with showing us data that were kind of going against the, expectations. The data that you showed on BMI, the association between various forms or assessments of adiposity, measures of adiposity, and coronary calcium, where you showed instead of your, linear relationship, some sort of U-shaped or inverse J-shaped, and higher actually coronary calcium, perhaps with lower BMI. And again, something controversial, and I'm curious as to what you think might be some explanations. Have we seen this with any other diabetes-related outcome?
We see it for mortality. We see it for there's not really an association in type 1 anyway. We don't really see a relationship with BMI with cardiovascular disease mortality. The explanation might be, again, we're looking with it's the obesity paradox. So we're looking at within a population that's already diseased. And it could be argued that to gain weight, there's a certain amount of beating the disease, to use of, and so then we're also looking at they're metabolizing and they're getting insulin, they're metabolizing insulin, so that's enabling them to gain weight. We controlled, so I didn't show you the full models with the tables, but we controlled for complications, we controlled for a number of different factors. And you also see this in many populations that have a relatively short lifetime. You see a survival benefit to being heavier. And you don't actually, it's not until you're looking at populations that are reaching old age that you start to see that effect of BMI not being protective.
Thank you.
Becca, I have a question about maybe some of your bigger picture future directions. It looks like you've got an interest in diabetes and cancer. Is this an area you're going to keep pursuing, understanding, maybe shared consequences of the two, or?
I do want to keep pursuing that. It's an area I just started getting into, so I do want to keep, it's not going to be my whole direction, but I do want to keep looking at that, yes. So I have another, I mentioned the incident diabetes with iron. I have another one I put in looking at liver cancer. And as I mentioned to some of you, although I put both granted at the same time, the incident diabetes was scored, the liver cancer was not, although the liver cancer had a more favorable review. So I do want to try that one again. And that's also with iron in blacks.
Do you have any plans to look at maybe social determinants of health, given your current focus on these Black-white disparities?
So that will be something I'm going to be branching into. Yes, I haven't looked much into at that. Actually, for me, it's usually, I guess, perhaps because of the training I came from, where it's really largely clinical factors that we're looking at. The most I've looked at was probably health insurance and very basic health insurance, income and education. So, but that is something I will be broadening my scope for.
I'll ask one more question if no one else has any, but if you do, I would much prefer to hear someone else besides me talk.
Rebecca, thank you for the presentation. I'm just curious about the small grant that you said about breast cancer. What is that about?
So there's a cancer concern. So I got into the small business set aside. They contacted me, and even though I've never done anything in breast cancer, I wasn't going to turn it down. So I put in, so what that is, back in April, it's called what's a sources sought, and they're seeing what the interests are is in someone wanting to, I guess they sent out to a number of people, and I went for it. Was the first. This is the first monies I went for with the business, my new company. And then a few weeks ago, they asked us to put in make a bid, like a quote. And I put my quote in and they accepted it. I got it. So.
Oh, congratulations.
Thank you.
I'll just mention that here at CU, there's a cancer center that had contacted Dr. DeBalia about collaborations with life course epi and obesity related outcomes in relation to cancer outcomes, and they are looking to fund some pilot programs. So there's certainly room for collaboration for you to grow here.
They're very interested. They're very interested. So
Great.
Yeah.
Thank you.
And I guess one question that I have for you, maybe to end this, is what do you think you could leverage here at CU, knowing that we have this center that focuses quite a bit on diabetes, both type 1 and type 2, and with data across the life course?
What do I think I could leverage? I'd love to leverage, I was talking, I love to leverage the search study. There's a new study, I can't pronounce it because it's a new study to me that you mentioned to me earlier, DIA, but the CDC, the newly funded study, looking the surveillance study, looking at diabetes.
Such
Yeah,
an awful name.
So that study, cacti apparently is still running. I'd love to be involved with that. The cacti study again, doing research with the calcification. I would love doing that. And then you have the research in PFAS. I'd love to be involved in that. As far as your group with the interesting name of, I can pronounce it here, the Laboratory for Analytic and Computational Epidemiology. I'd love to do some work with them. Yes.
Well, that's great. We're almost at the top of the hour. So I think what I'll do is thank you for sharing your work with us today and taking the time to chat with us. And I guess we'll have a round of virtual applause for Dr. Conway.
Thank you.
Thank you, Dr. Conway.
Thank you.